This is Going Under Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh, and we're brought to you by the Butterfly Network.
When it comes to successful ultrasound-guided procedures, precision is everything. That's why IQ3, Butterfly's handheld POCUS device, contains advanced features to support procedural success. With Butterfly's needle out of plane preset, you can visualize the needle tip within 1 millimeter after insertion. Butterfly's biplane imaging, the only multi-plane imaging in a handheld ultrasound, lets you see both short and long axis views simultaneously in real time. And Needle Viz enhances your ability to track the needle in plane from entry point to area of interest. Butterfly iQ3 also delivers image quality similar to POCUS systems that are cart-based at 1/10 the price. And unlike a cart, you can carry it in your pocket to conveniently use where you want, when you want. So whether you're inserting IVs, conducting cardiac assessments, performing regional anesthesia, gastric evaluations, lung ultrasounds, or anything in between, the Butterfly iQ3 is the perfect probe for your practice. Visit store.butterflynetwork.com to claim a soft case with the purchase of your iQ3. Use code BRIAN25 at checkout. Terms apply.
And you've got a hard case, too.
I do have a hard case, too. The hard case is amazing. I know you don't get it, as a, well, we can't say the G word, but you don't get it as an additional product.
Yeah.
But yeah, the hard case is awesome. It's like $150 or something like
Nice.
that. I carry it everywhere. In fact, I'm going to a hospital in Northeast Indiana tomorrow and taking it with me. So
It was awesome to see you kind of like bust it out. Like
pulled it
right
out. Yep, sure did. Yeah.
And we are going to be kind of talking about POCUS devices.
Correct.
Because one of the shows that you're really into right now is using a POCUS device.
Yeah.
They're not using the Butterfly, are they?
Well, apparently...
we can't say?
We can't say. I don't think we can say. But no, there was no Butterfly, at least in the 10 episodes I've watched. So I'm sure anybody who's on social media, watches TV, does like the whole binge watching thing, has heard of the show The Pitt. So it's like it's almost like, I can't say this either because they're in litigation, but it's sort of like an old show that happened in an emergency room.
Got it.
Yeah. Yeah. Apparently there's some litigation going on there too. But it's really good. And it's got Noah Wiley in it, who was in the original show that took place in an emergency department.
It's like the show that shall not be named.
That's right. But no,
the device that shall not be named.
That's right. But it takes place in Pittsburgh, so they call it they call the ER the Pitt.
Okay.
And it goes through, basically it's almost like the show 24. Have you seen the show 24?
Oh yeah, I used to binge watch that show.
So every hour is actually an hour of real time in the show, which is kind of cool because when you go in the ER and you're working, you work at a shift that's a certain number of hours. So it's like everything that happens within that time.
So the season is like 12 hours only.
I think it's 16 or so. They're scheduled for 15 or 16. But yeah, so it starts out at like hour 1, 7 a.m., right? You're walking in and here's what you get. What's really cool about it, so like that show that took place in the emergency department way back when, It wasn't super realistic, right? And it wasn't, I don't know. There was a lot of just like inaccurate.
You're talking about the other show.
The other show, yeah. There was a lot of inaccurate medical stuff. So far, everything I've seen in this show has been pretty much 100% medically accurate. And I had read something where they hired like 4 or 5 medical consultants for this show, and they didn't really do that with that other show. So the Pitt, the Pitt is really medically accurate.
Yeah.
Which is really cool to watch. And there was. So I've got to share this, and then I'll get into part of the reason I wanted to talk about it. But they had, and there's going to be some spoilers. You should put something in that there's some spoilers because I watched all 10 episodes that have been released this past weekend. So just a heads up, I'm excited about the show. There's a kid that comes in with a tonsillar bleed. So he had a tonsil procedure. There's a lot of drama around it. But anyway, what they did to treat it, I'd never heard of before, so I had to look it up after they said it. They used nebulized TXA. It's called transexamic acid, which is a medicine we use in the operating room to prevent bleeding. Apparently, you can put it in a nebulizer, nebulize it, and it causes the bleeding tonsils to stop, or where the tonsils were, the bleeding portion to stop. I was like, that's genius.
So it taught you something.
It taught me something.
Wow.
Yeah. So, but the other,
it's a good show.
Oh man, well there were a few things that I was like, oh, I don't remember. Yeah. That's why you do that. But because I haven't been in the ER since,
What do you think of the ER?
So it's really fun and exciting, but there's also a lot of, people who come in for a pregnancy test, like GI bugs, which scare the crap out of me, right?
Yeah,
so
right.
I don't want to get anywhere near anybody who has a GI bug. So
a lot of violence too. Is this like a thing?
Well, and that's another issue we should talk about during this. I guess we should just talk about it now. So violence against healthcare workers is a huge issue right now. Has been for probably 5 years, pretty much COVID, right? Like there was some violence against healthcare workers. You would see it from time to time, but it wasn't a common thing. During COVID, everybody was like, "Oh, thank you, you're our heroes," blah, blah, blah. And now, with healthcare, there's a shortage of nurses, there's a shortage of doctors, there's a shortage of finances, meaning that they're closing, hospitals, they're closing rooms in hospitals, all that sort of stuff. There's a lot more angst in the public because if they show up at the ER, what used to maybe be a 3-hour wait is now a 12 or 13-hour wait. So there is a lot more violence against healthcare workers, and it's a big thing both with nursing and with physicians that there's a big push on social media. There's a big push, and really there should be. Like there is no excuse for a healthcare worker to be accosted or assaulted because of something in the ER, having to wait in the ER. And there is something, again, spoiler, there is a portion of that show where they were attacked. One of the nurses was attacked, but it's gotten to be a really, really big issue. You look, there's been 4 or 5 shootings in hospitals.
Yeah, Pennsylvania was the most recent one, right?
Yeah, and it's usually disgruntled. What? I don't want to overgeneralize, but a lot of what these shootings in hospitals used to be were domestic disputes between somebody who worked at the hospital and somebody who didn't, and that person would come in and cause problems. Now it's oftentimes patients, family of patients. There's a lot of stuff going on, I think, internally because of the healthcare system. And it's great. Noah Wiley's character says to the CEO of the hospital or CMO of the hospital, "Hey, how about you hire some more nurses so that I can get these patients who are boarding in the ER for hours out of here so I can see more patients? Then maybe satisfaction scores would go up and my nurses wouldn't get assaulted. What are you doing to
help that?
To help that, yeah. Sure. Well, there's a nursing shortage and we don't have the money to blah, blah, blah." They also bring in, this is great, you can tell I'm excited about the show. They bring in some person in a suit who also has a medical degree, who's backed by private equity, and we all know how much we love private equity, who's threatening to buy out the ER group because their satisfaction scores aren't good enough and they're not seeing enough patients and making enough money. So they really skewer hospital administrators, they skewer private equity, all the things that we talk about on our podcast that are driving up the cost of healthcare and driving down the quality of healthcare.
So I wonder why this is the case. I wonder just why maybe over the last 20 years you're seeing, obviously we saw the shooting in New York,
right,
with United Healthcare CEO.
Mm-hmm.
But why are people resorting to going in because their wait time is an hour? Why are they resorting to violence? Why wasn't this? And I'm not saying we should have. I'm just saying, why in the 1980s did they not resort to violence? Why are we hearing about it now? Why is it happening more?
Well, it's probably twofold. It is happening more for sure, but we hear about it more because of social media, 24-hour news cycle, all the reasons you hear about everything more. I also think that healthcare in general is egregiously money hungry. So now patients see that, right? That's why there was the stuff with the United Healthcare CEO. That's why they're coming in and beating up nurses because the nurse is the face of the hospital. Well, the nurse is not the one making the decision not to hire enough nurses so that you can't have rooms upstairs so that you're stuck in the ER for 3, 4, 5 days, right? I think it's become more egregious and more exposed since probably COVID. I mean, you say 20 years. Yeah, it's gotten worse over 20 years. But I think people also now know how egregiously greedy the healthcare system, not doctors, not nurses, not clinicians, but the healthcare system, hospitals, insurance companies, these group private equity, how egregiously greedy they are.
It's making a lot of people upset.
Yeah, it is.
I mean, it is. And that's why we're seeing shows about it. That's why we're seeing it more in the news. Mm-hmm. Obviously, the 24-hour social media cycle controls everything.
Oh, yeah.
You and I have talked about this on a separate topic. We have talked about, my gosh, are there more plane crashes?
Right.
Are we just hearing about them more?
Yeah.
Because there have been plane crashes.
Right.
There have been helicopter crashes. There have been aviation disasters over the years. But we're hearing about it now.
Well, it's the same.
Everybody has a cell phone.
Right, exactly. It's the same reason we're talking about this show, or last week, or the Pitt,
Right.
or last week you talked about the measles, right?
Let's address that too.
Sure.
Yeah.
What's popular or what's highly viewed is what the news focuses on. So when there's a couple plane crashes and that gets a lot of views on social media, on news, whatever, they're going to talk about every plane crash that happens. If the plane crash nobody cared, right? Because something else was happening, right? Everybody cared about, the unaliving of somebody else, right? Then they wouldn't play all that stuff. So that's part of it. If you look at the statistics, there aren't any more plane crashes now than there have been for the past 25 years. So yeah, we can talk about measles at some point, but no, I mean, I think the other aspect of why are patients so mad, and and why does this continue to be a problem with assaulting healthcare workers? The hospitals haven't done anything about it, right?
Meaning, like
they haven't. So
like there's still the same amount of security,
right? Yeah, they're not putting any money, effort, or time into protecting healthcare workers. So I mean, a lot of hospitals don't have security. A lot of hospitals,
and if they do have security, it's not like it's locked down security, right?
So I did my training at Wishart Hospital in Indianapolis, which is now Eskenazi Hospital. They had they had like police officers, they had guns,
and you couldn't go through.
Nope.
Right.
Yeah. I mean, it was very difficult for a patient to get to a clinician. Now, again, this is 20 plus years ago, so it's not like we were getting assaulted as often, I don't think. But I mean, they're not doing anything either to really go after the perpetrators, right? They're treating it, and this is a big trend on social media too. They're treating it as like just cost of doing business, which is completely unacceptable.
Right.
So,
I mean, I look at going into the television station.
Yeah.
And I don't know if this is true everywhere, but the one I've worked with over the last decade or so, there are multiple layers to getting into the building.
Yep.
And is it foolproof? No, there's always a way around something, but it's pretty darn secure.
Yeah. No, and if you... So security costs money. Goes back to the same thing. Greedy healthcare system. Security costs money. If you're going to spend the money on a security guard, on metal detectors, on all that kind of stuff, if you don't have to, if the only people being assaulted are the clinicians, who most hospitals see as just another widget, I don't know. I mean, this is getting me fired up, and it wasn't the direction I thought we were going to take today. But I mean, it's a huge issue, and I haven't personally been assaulted.
Sure.
But I've had to step in when I thought a patient was going to do something to one of my nurses. I mean, I've definitely
You had to step in.
I've definitely stepped in between.
Is it verbal assault? Is it
Both.
physical assault?
Both. Yeah, both. I mean, I'm
Threats?
Yeah, threats and aggressive behavior, yelling, screaming, cussing them out. I mean, I'm not.
Can I ask you over what? Like, what was the impetus of the conversation?
Yeah, the two examples I can think of. One was that the nurse wouldn't let the patient keep some piece of clothing on to go back to the operating room. It's our policy. You take all of your clothes off, right, for everything except basically a cataract.
Sure.
And the nurse was like, "I'm sorry, you can't leave that on." And the patient got really upset. I could hear it. I was out in the pre-op area. I could hear him like yelling at her. And then I walked in and I said, "You need to stop. This is our policy. If you have a problem, you can talk to me." And then he backed down because, I mean, I'm not huge, but I've got some muscle on me, so I can, I've
seen you work out. You can bench press it a little bit.
I can command a little bit more
sure.
Authority just because of my size, right? So
it's really interesting.
Yeah.
It's really interesting how even, and I'm going to say this.
Yeah.
Even healthcare has become hyper political.
Correct.
And I don't know if this was the case. You can obviously speak better of this than me. But 20 years ago, 30 years ago, going to see a doctor wasn't political. It wasn't based on who you voted for. And now I get flack because of the car I drive, right? Or I get flack because of the side of town. It's all based on political. But I feel like there is only a few who will do that, who will say, oh, you know what? It's become political now. You know, the viewpoints of your politics is based on everything that you do now.
Yeah.
There's no like middle ground of, hey, like this is just our policy.
It's all about money. This is all about money. That the more that,
if you know what I'm saying, if you kind of
absolutely, yeah. The more that the 24-hour news cycle, that all of the media can divide us and make it left, right, like Tesla driver versus Prius driver,
Correct.
right? Like, I mean, they want to divide us because, again, that's views, that's money, that's advertising, that's what it's all about. And the more connected we get, social media, 24-hour news cycle, the more they're going to do that, the more they want to drive people apart. No, absolutely, it shouldn't be political to go see the doctor. It shouldn't be political. I mean, most of these things shouldn't be political. It certainly shouldn't be political for me to say, RFK said, get your measles vaccine.
because you said RFK.
Exactly, yeah. I just said it again. It's like a big buzzword.
Right.
So, yeah, I mean, it's all related to that.
But there are physicians out there who are letting their politics be known. Is there room in that in day to day, right? I mean, is there room for that?
I think if you can be reasonable and have a reasonable conversation about a topic,
sure,
and not say, you know, you're a bad person because you think X because I think Y. No, I mean, I think it's reasonable to say my opinion on whatever taxes is this. What's your opinion? Okay, let's debate.
Correct. And have a civil
discussion. Right.
Where should politics? This is a general question, but I'm going to ask it anyway because we're talking about it.
Yeah.
Where should politics ultimately land in the world of medicine? Where should we be?
Well, I think in general, medicine should be apolitical, right? I mean, we're supposed to do everything based on evidence in medicine. So really, we should be looking at the evidence and, you know, if the evidence says do this, do it. Who cares? And I go back to Jerome a lot, but like I've said many times, Jerome Adams, I don't know who he voted for in 2016, 2020,
Correct.
2024, even though he was the Surgeon General under Trump and worked also in Indiana under Mike Pence, both Republicans. I can't tell you that he voted for either one of those guys. I don't know. He's pragmatic.
But you also don't care.
Evidence. No, I don't care. Yeah,
exactly.
Not a bit, right? He looks at the evidence. He does what he thinks is right based on public health, you know, decision-making, public health policy. What's best for the country as a whole. So, I mean, I think we should be apolitical. Now, can we truly be apolitical? No, we can't be apolitical. Right. But let's try as much as possible to just follow the evidence.
Yeah, it's a good thought. I mean, if everybody didn't come after you after the RFK comment, we'd be in a better place.
That's exactly. It was kind of fun actually to say, you know. So we'll get into this just briefly, and then I want to talk some more about the Pitt.
Sure.
But what I said in that clip and what I said in the entire podcast was that you should vaccinate yourself against, you should vaccinate your children against measles, and if you're of a certain age, you should check, and you haven't had a measles vaccine, you should check with your, not because you just decided you didn't want a measles vaccine, but it wasn't available at the time when you were that age, you should check with your doctor or the CDC about whether or not you should get a measles vaccine, which is absolute. I stand by that 100%. What people didn't like is I said, RFK said, get your measles vaccines, get your kids vaccinated. He's the HHS secretary. What I mean,
right. And whether or not whatever you believe in, you were just...
I was repeating what he said, and then I said, that's the right thing to say at this point. You should get your measles vaccine.
And then I kind of love that people... This is your podcast, I can say this. I just love the fact that people were like arguing whether or not they should listen to the podcast. Listen to the podcast, because he clearly spelled it out for you there.
It's called a teaser for a reason, right? I mean, the whole point, and I don't put this on just the social media, but the whole point of the teaser is to get you interested to listen to the podcast. Anyway, okay, so back to the Pitt. So what the other thing that was fascinating to me, so I did my ER rotations, again, almost 20 years ago. Patients came in, You evaluate them with a physical exam, and then you send them to some sort of imaging, CT scan, X-ray, blah, blah, blah. You know what every patient got when they got in there in this? And I assume it's actually what's happening in ERs. They got a POCUS exam. Literally every patient they had an ultrasound in basically every room, or they carried an ultrasound into every room. Triage, trauma, everything. Everybody got a POCUS exam. Heart, lung, liver, abdomen, chest, everything. They got POCUS exams on everything, which is totally different than when I trained. So
like when you were trained, I mean, you had a stethoscope?
Yeah, stethoscope, physical exam. I did a
but
physical exam.
But there was a room for everything, right? Like if you're going to get a, sorry to interrupt, if you're going to get like a ultrasound, there was a room for ultrasound, right?
Right. There wasn't an ultrasound sitting around. We didn't hardly use ultrasound at all. And we'd send them to radiology for even an ultrasound, X-ray, CT, MRI. Yeah. They go to ultrasound for all that stuff, or they go to radiology for all that stuff. Every single one, the medical students even were like just grabbing in the show. We're grabbing the ultrasound, scanning the patient. Oh, there's no pericardial effusion. There's no blood in the abdomen. Like it's a totally different world. And you gain, and we talked about this at the conference, you gain so much knowledge
of the patient
just by doing that ultrasound, right? And they even talked about, should it be history, scanning, then exam, right? Should you do your scanning before you even do an exam?
So can I ask you a question about the ultrasound device?
Yeah.
So specifically, I'm talking butterfly now. But when you use the needle, obviously some ultrasounds don't require a needle, right? I mean, you can do an ultrasound on somebody who's pregnant.
Yeah.
And that's gel, right?
So that's diagnostic ultrasound versus doing like a regional anesthetic or something. Right, yeah. So what they were doing is all diagnostic. Well, I mean, they actually did a pericardial effusion under ultrasound, which I've never done before, but I may have once or twice. But yeah, so they drained a pericardial effusion under ultrasound. So you can use it for that, but their basic use was just diagnostic, taking it, looking at what's wrong,
blood flow,
right,
whatever.
Yeah, right.
But if you're taking the needle, you're actually doing either a block or some sort of
or something. Yeah, right. Yeah,
that's interesting.
Yeah.
I feel like for those who don't know, because I didn't really know this was out there, until last year, obviously.
Yeah,
and just to see how far the technology has come.
Yeah, it's unbelievable.
Is crazy and what they're thinking of.
Yep.
Right? I mean, everybody talks about, and I think we've talked about it ad nauseum, like AI, and I think everybody's talking about AI, and everybody's talking about AI in bad terms, in negative terms. Yeah. Oh, like it's going to take people's jobs, and it's going to take people. I don't think it is.
Nope.
I think AI is going to make what we do better.
Yep.
And more effective.
Especially in medicine, for sure.
100%. And so, I mean, content creators use AI all the time. I use AI. Am I using it to write scripts? No. Am I using it to help the time it takes me to do things?
Oh, 100%.
Absolutely. When it comes to like editing reels or like doing that sort of thing. But it's not tried and true. It's not 100%.
Not yet. Yeah.
But I feel like what we're using, what you're using, what Butterfly is using AI for is making the patient experience better, making the physician's job easier.
Correct.
So they can have, every provider can have
their own
POCUS device.
Yeah. So the other thing I think is great is if you look at, and we may have talked about this before, if you look at the studies on radiology, they did studies where they looked at AI only. So AI was trying to make the read, physician only, just the physician trying to make the read, and then physician with the help of AI. They're synergistic. The reads were infinitely better if the physicians were doing the read, but with the help of AI. They were better than both the physician doing it themselves and AI doing it themselves. So, I mean, it makes sense that you use AI as a tool, not to replace.
So it sounds like, let's go back to this before we kind of wrap it up.
Yeah.
It sounds like the Pitt has it all, basically.
Everything
that we just talked about in the last 20 minutes.
All of it. And the other thing that they do, they use video laryngoscopes, which didn't really exist when I was a medical student, or at least nothing that was decent. Now they got video laryngoscopes sitting there all over the place. I use the McGrath, which is a handheld one, but they've got a glide scope in there. They've got, everything is totally different, which I just kept watching and I was like, I cannot believe how different this is than when I was training. And
Yeah.
and it wasn't that long. I guess it was almost a generation ago now, but it wasn't that long ago. So it's a great show. And I did. So it's a little overly dramatic at points.
That's
and there's
a television
And there's
show.
actually one other thing I want to get into, which we talked about,
Yeah.
which is the drug use by
Okay.
medication use, substance.
Did they
use
talk
by-
about that too?
They do. Yeah,
Okay.
yeah. So again, spoiler, but no, I mean just the difference, and it's a really good show. Literally a little over dramatic at times, but you got to throw that in, right? It's most people watching it are not physicians who are like, oh, that's so cool, oh, it's so different, right? So you got to throw in some of the drama. There's some relationship stuff, and there's some
Better than Grey's Anatomy?
I never watched Grey's Anatomy.
I feel like Grey's Anatomy was like a medical show for non-doctors.
I see. Yeah.
You know what I mean?
I
like,
never watched that.
Just people who like drama and, you know.
So the shows I watched were that other show that takes place
Sure.
in the
Emergency
department.
room.
Yes, correct. And then House. And House was not super realistic either. It was based on real cases, but what actually happened in the hospital was not realistic. This pretty much everything I've seen was pretty realistic. So the other thing that we should talk about, and hopefully we're not running out of too much time here, but the other thing we should talk about, and it's something that we think about a lot in anesthesia because of the medications that we have access to, but also ER makes sense, is drug use and abuse by physicians and clinicians in general, but physicians. And so in my career, I've known 3 anesthesia providers who have abused medications that they were supposed to give to their patients. And so the reason I bring this up is that the last, again, spoiler alert, don't listen if you haven't watched the show, but there's a physician in the show that is stealing medications, both from the Pyxis, where they keep IV medications, and from even patients when he's filling their scripts. Now his drug of choice was benzodiazepines, which are like anti-anxiety medications. Most anesthesia providers, if they get hooked on an illicit medication, it's fentanyl, which everybody's heard about, right?
Yeah, right.
And actually, that's a good point. There was a whole episode, 2 episodes of it, based on kids taking illicit medications that had fentanyl in them, and so that's a whole nother point. We should talk about that too, about Narcan. But so in general, the percentage of physicians, clinicians who use, and anesthesia in particular, who use substances illicitly it's the same percentage as the general population. It's about 10%.
Right.
I haven't looked at this data in a couple of years, so it could have changed slightly, but that's what the data said then. The problem is that physicians, clinicians, particularly people in the ER or the operating room, have access to medications that are way different than the general public. The general public almost always abuses alcohol or some medication that they got, like an opioid pill that they got from their neighbor or their friend or whatever, right? Those 2 medications, or those 2 substances are difficult, right? Difficult to get off of, but there's programs for that. And the other thing is that the general population doesn't have access to those substances 24/7, 365, right? The problem is, okay, let's say you have 10% of anesthesia providers who are using drugs, and a percentage of those are using fentanyl in the operating room.
Is that a close number, or is that?
Yeah, it's probably 10%, about 10%
Wow.
of the population.
That's 10 in 100. I mean, that's
1 in 100.
that's quite a bit.
Yeah, or 10 in
10 in
100.
10 in 100.
1 in
That's
10,
quite a
yeah,
bit.
Yeah. And that's what the data would say. So there's 2 problems, though. So fentanyl is insanely addictive, right? So it's almost impossible to get off of. And when you go back to the operating room, let's say this happens quite a bit. Somebody gets caught using fentanyl. If they don't die from using it, they get treated and they come back. Well, they come back and they're still having to be in an atmosphere where they're using that drug. So it's like an alcoholic having to be
Working
in a bar,
right,
handing out whatever their drink of choice is to everyone all day, every day, right? So you put them back in an environment like that, the recidivism rate is super, super high.
What are the checks and balances for
Yeah.
physicians? I mean, like, you obviously, for somebody who is part owner, of a
company,
surgical
yeah, right.
center, a company, a surgical center, I mean, there's not really anybody watching you, right? Or is there somebody?
Yeah, so those drugs are under lock and key in some way, shape, or form. It depends on the facility. So the problem comes in though. So if you take them out of there's a couple of major companies that make these big devices that distribute the medications. You have to count them and all. So Pyxis and Omnicell are the two big ones. They count the medications, right? They make sure that nobody's taking those scheduled medications out and not using them or stealing them or whatever.
Okay.
So it's pretty good if it's just straight theft, right? The problem is that you take that medication out. If I have a reason to use fentanyl there, and I'm not going to describe it on the show, but there's ways that people who are diverting medications and using it for themselves can never get caught on an Omnicell or on a Pyxis. Right, it's not.
So they've figured out the system.
Correct. It's not just taking the medications out. There's a whole lot of other steps that they can get around. Okay, so and again, I'm not going to describe what people do, but so it's not 100% foolproof way to protect from use and abuse. So I mean, you have to look out for the signs and all that sort of stuff. So
did your PhD thesis on this, or is
no?
this...
So I did neuropharmacology. We did molecular mechanisms of conversion of acute pain to chronic pain.
Okay.
So we studied sort of the things that happen within a cell that is having acute pain that turns it into a cell that's going to respond inappropriately to pain and cause a chronic pain syndrome.
But you're pretty passionate about this
Oh yeah, the opioid stuff for sure. Yeah,
subject specifically.
Definitely. And then the other thing. So I'll just push this even further. So there's 2 episodes. Again, spoiler alert. 2 episodes where kids have taken pills that they got off the street that they thought was something that they wanted that had fentanyl in them. One of the kids ultimately dies. The other one, they do a nasal spray of Narcan, which is great.
Yeah.
Everybody should carry, and this is a thing that Jerome Adams talks about too, is everybody should have Narcan somewhere that they have access to. It's over the counter. You can walk into Martin's anytime and say, I want to get a Narcan just in case I ever see anybody who's had an opioid overdose. And it's nice now because you don't have to inject it or anything. It's just intranasal.
It's nasal.
Squirt it up the nose. So this one kid dies, the other one comes in, and they spray it up the guy's the teenager's nose, and she wakes right up, right? So so shameless plug again for the show, super realistic, right? And they handle a lot of really, really tough issues. I mean, everything we've talked about today in the 30 plus minutes that we've been talking are issues they've talked about. So
The Pitt on
Pitt.
Netflix?
I believe it's on Max.
Max.
Yes.
Okay. I'm sure you can find that somewhere. Awesome. I'm going to have to check it out. Now, there's 2 shows that I have to check out now because the people in my life are just talking about them nonstop.
What's the other one?
You with The Pitt.
Okay. What's the other one?
The other one is called Paradise.
Okay.
And it's with the guy who was in This Is Us.
Okay. Yeah,
and it's like kind of like an end of the world kind of scenario.
Interesting.
But apparently, like you can't not watch. Like it is.
Can't stop watching.
Phenomenal.
Nice.
Called Paradise. But this is called The Pitt.
The Pitt. Yeah.
It's been a good conversation.
Yeah, I believe so. Really well done show. I highly, we're not sponsored by The Pitt. We have no connection with them, but it is a really, really cool show. Super excited about it. And I think it brings up a lot of things like we talked about today. So I think we should delve in more at some point about all this sort of stuff. But it's a pretty good show.
I'm in. It's awesome.
All right.
And I'll report back to you with the first episode of The Pitt. We are brought to you, however, by Butterfly Network.
Yes, we are.
The handheld POCUS device, the Butterfly IQ3. If you've seen Brian if you don't follow Brian on social media, well, we should. He's very entertaining. Says some controversial things now and again. And he always carries this Butterfly device with him wherever he goes. So, all right. Well, thanks, Brian.
Thank you.
This has been Going Under, Anesthesia Answered, brought to you by Butterfly Network. I'm Vahid Sadrzadeh. We'll see you next week.
Sounds good.